Hi, good afternoon. My name is Dr. Judd Moul. I'm a urologist at Duke University Medical Center in Durham, North Carolina, and I'm really delighted to be on the program today, BioConference Live Cancer Research, Discovery, and Therapeutics. And over the next 45 minutes to an hour, I'm going to be discussing PSA screening, early detection, and prostate cancer 2013, controversy and opportunity. And hopefully there'll be plenty of time for questions. At the end, I'll give everyone the information for claiming CME credits. And again, just delighted to be here. So I bring greetings from Duke Urology, Duke Prostate Cancer Center here in Durham, North Carolina. I'm in a full-time clinical practice. We have a multidisciplinary program involving urologists, radiation oncologists, and medical oncologists, and we all work together caring for men with prostate cancer. And we see a lot of men coming in with PSA elevation, referrals from primary care. And this is going to focus on the PSA screening controversy and how to use PSA more effectively. So the outline of today's program is really going to be three aspects. Number one, we're going to talk about the PSA screening debate, the huge controversy surrounding whether we should use PSA to screen for the early detection of prostate cancer, or should we abandon this test. Number two, we're going to talk about how we use PSA intelligently and rationally in 2013 for risk assessment of the individual man, and how to use it for differential diagnosis for prostatic disease. And then we're going to talk a little bit about PSA and monitoring prostate cancer and defining progression after a man has been treated with surgery or radiation for early stage prostate cancer. So as far as the screening debate, over the next several slides, I'm going to be using newspaper headlines and other media to try to, illustrate this debate. Before I do that, this is a slide on PSA poster boys. And basically what it's illustrating is a lot of the famous men in the United States who've been diagnosed with prostate cancer and who have overall touted the benefits of the PSA test. And certainly some of these men have been responsible for the uptake of PSA screening, promoting prostate cancer awareness and screening efforts. Certainly where I live in the southeastern United States in North Carolina, every region of the country has their favorite poster boy, and our poster boy is Richard Petty. For those of you who are tuning in this afternoon and are not familiar with Mr. Petty, he's certainly a famous NASCAR driver, and in our state he's referred to as Sir Richard. But he was treated for early stage prostate cancer, and certainly was an individual who was benefited by early detection in the PSA test. Now, about a year and a half ago, in May of 2012, the United States Preventative Services Task Force gave the PSA test a D rating, which basically means that this agency or independent panel felt that there was more harm than good to PSA testing. And the $64,000 question is, did this committee get it right? Or is there value in PSA testing that the committee did not consider? And you see here, this was a headline about this in USA Today at about that time. And in many of the medical journals, this was picked up. This happens to be a follow-up article about this in JAMA, which again talked about the pros and cons of this U.S. Preventative Services Task Force decision. But on the other hand, the U.S. Preventative Services Task Force made this recommendation against PSA, but during the PSA era, we've definitely seen a decline in prostate cancer mortality. And so how do we reconcile some of the data that where we're seeing a decline in mortality, yet the task force was against the PSA test? And what we're looking at on this slide is data from SEER, the Surveillance Epidemiology and End Results Program, basically illustrating that the death rates from prostate cancer went down from 1997 to 2007. And the $64,000 question, was this due to the introduction of the PSA test, or was it due to aggressive treatment, or was it due to a combination of factors? And how much was the PSA responsible for this versus other factors? And again, that's where the Preventative Task Force and some of the other guidelines committees have differed in their opinion of this. Some would say that this population data from the United States on decreasing mortality may be similar to what happened with cervical cancer and Pap testing, where we saw dramatic declines in deaths from cervical cancer as a result of the Pap test. On the other hand, other people say that you can't make that comparison, and prostate cancer is different. Now, what has also been seen is that the rates of metastatic disease have declined in the PSA era. In other words, what we are looking at here is guys with prostate cancer who, when they first come to medical attention, have M1 or metastatic disease. And in the PSA era, we saw a dramatic decline in this situation. And what you can see on this particular slide here is that the rates of metastatic disease in the PSA era have very much declined. And many experts feel that PSA screening and PSA testing has been largely responsible for this stage migration. And furthermore, many people say, well, gosh, if the metastatic rates have declined this much, surely there's a benefit to PSA testing, and surely these metastatic rate declines will translate into a population benefit as far as overall survival rates. But yet not everyone believes this, and the U.S. Preventative Services Task Force, again, was skeptical of this and currently is still calling for a D rating for the PSA test. Now, what I'd like to do over the next several slides is give a brief overview of some of the completed and ongoing prostate cancer screening trials. Some of these trials have higher level of evidence than others, but taken together, they all seem to suggest a benefit to PSA testing for the most part. The first trial, which was done in Quebec, Canada, by Professor Ferdinand Labrie, supposedly was a randomized trial that looked at PSA screening in the Canadian province of Quebec. And it was published in the journal The Prostate in 2004 and was the first published trial or supposed randomized trial that showed a benefit. Later, this trial was discredited because of methodological flaws with regard to the control arm. And so most people, even though this is published in the peer-reviewed literature, most people would discount this trial and currently do not really use this trial in their decision-making regarding the PSA screening debate. Now, another line of evidence was from Tyrolean region of Austria. And this was a population-based, non-randomized experience where they introduced the PSA test selectively in a region of Austria, and whereas the rest of the country did not subscribe to PSA testing. And the advantage to this study was that at this time, there was very little migration in and out of Austria, and there was very little migration of the population within the different counties. So we can get some pretty interesting data here. And what this slide is illustrating is that when we look at when the PSA test was introduced, we see that the incidence of prostate cancer went up. Not surprisingly, when you introduce a new screening test to a population, the incidence of disease goes up, in this case, prostate cancer. What we see here is a marked example of stage migration after they introduced the PSA test. So if you look here in the green line, this is the rate of very early stage disease. The orange line is the rate of locally advanced prostate cancer, and the red line illustrates advanced prostate cancer. So when they introduced the PSA test to this closed population, they saw a marked stage migration, which is one of the definitions of a successful screening test. You do need to see a stage migration that would predate any mortality improvement from the disease. So they were on the right. This would suggest that PSA testing was on the right track. Finally, this is looking at population-based mortality, and we see here that the death rates from prostate cancer in red, that I've highlighted here in yellow, went down with the introduction of PSA testing. But the blue here illustrates the rates of prostate cancer in the remaining portions of the country, which did not go down. So the population-based mortality rates for prostate cancer went down in the area of the country where they introduced the PSA test, and did not go down in areas of the country where PSA was not being used. So this is probably a stronger level of evidence, but yet it's still not level one. It's not a randomized controlled trial. Now, the first published randomized trial, well, two publications together that appeared March 18, 2009 in the New England Journal of Medicine, was the PLCO trial, prostate, lung, colorectal, and ovarian trial. And this one looked at a group of 76,000 plus men from 10 centers who were randomized to either PSA testing or usual care. And the biggest problem with this study is the fact that 52% of the men in the control group, 52% had a PSA test. So there was massive contamination of the usual care arm, which in my opinion was a fatal flaw to this study. Nevertheless, the study was published in the New England Journal of Medicine and showed no apparent benefit of PSA testing. And that probably makes sense because half of the control group also had a PSA test. Now, this is just further evidence from the PLCO when it was published, again, showing no benefit to early mortality when prostate cancer screening was performed. But my take on this study is that it is fatally flawed and probably is not the level of evidence we would need to truly show if PSA testing was beneficial. Now, it is very interesting that if you look at the control group of the PLCO, and I just want to focus on this, men who had PSA testing in the control arm had a 25% decrease in prostate cancer specific mortality compared to those men who did not have PSA testing prior to randomization. Now, this has never been published in a high-level peer-reviewed journal, but it clearly points out that there were ways to look at this trial and try to account for the contamination of the control group, which would suggest that PSA testing is in fact beneficial. The other randomized trial that was published in the same issue of the New England Journal of Medicine back in March of 2009 was the European Randomized Study for Prostate Cancer Screening. And this was a large trial. This was 182,000 men who were aged 50 to 74. It involved 7 different European countries in the early 1990s. The screening group, or the screening arm, was randomized to receive a PSA test once every 4 years, which is kind of interesting and different than what has been traditionally done in the United States. And the control group got no PSA testing, and there was a fairly low contamination rate. Now, the key finding is that if you looked at this, that the cancer-specific mortality was improved by 20% in the screening arm. So when this was published in 2009, there was level 1 evidence of a 20% reduction in prostate cancer-specific mortality in men who were screened. So at that time, in March of 2009, we had one trial, the PLCO, that was fatally flawed, that showed no early benefit for screening, and a second trial that was more robust that showed a 20% improvement in mortality when men underwent PSA screening every 4 years. Now, the challenge with all screening and the challenge with the European randomized screening study was that one had to do quite a few prostate biopsies and do quite a bit of screening activity to save a man's life. And this is just one headline, supposedly that you would have had to biopsy almost 2,000 men in order to save one life for men with low PSA levels. And I just use this as an example of the pros and cons. The pro is you had a mortality benefit. The con is that you have to screen a significant number of individuals to achieve that benefit. The other issue that is very relevant to prostate cancer is the issue of overdetection. As I think all of us in the health field know, prostate cancer is unique in that there is quite a bit of indolent, occult, low-grade disease in older men. And one of the criticisms of PSA is that it picks up too much of this unimportant prostate cancer. And in fact, we know from this trial that even in men who are aged 55, about 25% of these men supposedly were detected with incidental or very early unimportant prostate cancer. And when you get up to age 75, the rate was as high as 50-50. That screening men at age 75, only about half of the cancers would be considered to be important. The other half, or 56%, would be considered to be incidental, or some people even call this autopsy prostate cancer, because it would have been there, the patient would have died with it and not of it. Now, in 2012, the European Randomized Screening Project reported updated data, and now with longer follow-up are reporting a 29% reduction in deaths from prostate cancer in the men who were randomized to screening. So the bottom line is with longer follow-up, the European trial has gotten more positive or more favorable for PSA screening. Interestingly, the U.S. Preventative Services Task Force apparently did not look at this updated data. And so the U.S. Preventative Services Task Force did not have access or chose not to review the latest European data showing a greater benefit for PSA testing. The next thing I want to mention is what's called the European Randomized Study of Screening for Prostate Cancer and the Goteborg arm. This was one of the sections of the European study, and specifically here we're looking at Goteborg in Sweden and a cohort of 20,000 men who were screened. Now, it's important to point out a couple of interesting things with this study. The follow-up on this study is much longer, 14 years, and what they found is a 40% risk reduction for prostate cancer mortality in the screening arm. In other words, unlike the overall European trial, where it was a 20 to now 29% or perhaps 30% risk reduction for prostate cancer, this sub-study from Sweden showed a 40% risk reduction in men who were screened. A number of other interesting factors about this particular European study. They use slightly different PSA thresholds over time. In other words, at the beginning of the study, their PSA cut point or threshold to recommend a prostate biopsy was 3.4, which then dropped to 2.9 and then dropped to 2.5. So they did make some modifications in the methodology over time. Another interesting fact is that the median age of men who were enrolled in this was only 56. This may explain the greater benefit because these were younger men who were followed longer and certainly had more to lose if they were diagnosed with advanced prostate cancer. And finally, the rate of metastatic disease was markedly different in the screened arm versus the control arm. So in the men who were randomized to screening, only 2.4% presented initially with metastatic disease, whereas in the control group, over 12% of patients had metastatic disease when they first presented. So that in of itself would be enough evidence for many experts to point to the benefit of PSA testing. And again, this was a randomized trial published in Lancet Oncology in 2010. It is not clear if the U.S. Preventative Services Task Force considered this study in their deliberations on the value of PSA testing. A final point on this European study was that they did not have PSA linked to treatment. And that's important because even though a significant number of these men were diagnosed with prostate cancer, 40% of the men who were detected on the screening arm and 30% of the men on the control arm were offered active surveillance. And furthermore, at the time of follow-up, again, this study was ongoing for 14 years, a quarter of the patients had not yet been treated. So again, the way they handled the overdetection issue was to offer a higher proportion of men active surveillance. That is starting to also be done now more properly in the United States. So I think it's important for us to de-link or to separate out the screening issue from the treatment issue. It's really not fair to criticize the PSA test for over-treatment. So, and in this study, they did not link the two, and many patients who had early stage prostate cancer were observed. The latest information on the European randomized study for prostate cancer, update 2013, shows that the PSA screening deaths were reduced by 32%. Now remember here, in 2012, it was a reduction of 29%, and that's important, but already now, 1 year later, they're reporting further improvement in the death rates by 3 more percent. So I think the key teaching point is with longer follow-up of this large screening study, as again, it takes a long time for prostate cancer to develop. It takes a long time for patients to die of prostate cancer. And not surprisingly, as this study matures, we are seeing the benefit of PSA testing grow with time. And again, the U.S. Preventative Services Task Force has not had a chance to consider the 2012 or the 2013 updated statistics. Now, where do some of the professional societies stand on this issue aside from the U.S. Preventative Services Task Force? Well, ASTRO, for one, feels that there should be a shared decision between the physician and the patient. And we'll talk about this shared decision in a little bit in just a few more minutes. Moving on to using PSA more intelligently and rationally, let's spend a few slides on this second area. PSA derivatives are things that have been used to try to improve the performance of PSA. And certainly time does not permit us from going into a lot of detail, but PSA density is used, age-specific PSA, PSA velocity, and free PSA. And these are all tools that both urologists and primary care physicians can use to help improve the performance of PSA screening. I just want to say a few words about age-adjusted PSA. And the key teaching point here is that as men go from younger to older, the normal PSA typically increases for both Caucasians, African Americans, and Asians, and it can be slightly different for the three ethnic groups. And the primary reason for this is as men age, they develop more benign prostatic hyperplasia, which accounts for some increase in normal PSA. So again, the key teaching point is trying to use age adjusting of the PSA in clinical practice to make better shared decisions between you and your patients. Now, the AUA stands for the American Urological Association, and they've had a number of guidelines over the years surrounding PSA testing. The guideline that was published in 2012 was quite aggressive in favor of PSA testing and suggested that all men should get a baseline PSA at age 40, whereby this baseline PSA could determine a man's future risk of prostate cancer. And I personally think that this is a valuable concept and something that should be embraced. However, as I'll show you in a minute, it's not part of the 2013 guidelines. In 2013, the AUA reassessed its position and came out with new guidelines in May during the national meeting. And these guidelines have been somewhat controversial. Some would say very controversial. First off, they do not recommend population screening. They discourage PSA below the age of 55 unless the patient is of a high-risk group, meaning he has a family history or is of African American ethnicity. And they do recommend PSA testing specifically between the ages of 55 and 69, and where the PSA testing is done every other year. And then finally, they discourage PSA testing at or greater than age 70, or when a patient has less than a 10-year life expectancy. Now, the guidelines here, and focus your attention right here on the PSA between 55 and every other year. This is right from the Goteborg arm of the European trial, where there is current level 1 evidence in favor of PSA testing in this specific age group of 55 to 69. So the AUA Guidelines 2013 are using pure level 1 evidence to come up with guidelines about PSA. And I would say the good news is that the AUA guidelines are promoting PSA in men 55 and 69, which in my opinion is much better than the U.S. Preventative Services Task Force giving it a D rating. The only thing that I was not too happy about was that I did think that there's still value in the baseline PSA assessment starting at age 40. And also, I do think that the AUA may have wanted to take a slightly stronger recommendation in favor of testing for those men with a family history or of African American ethnicity. Now, what are some practical PSA guidelines that we can use in practice? Well, and these are somewhat my opinion, but I do think that men should consider getting a risk assessment PSA level at age 40 to 45 to determine what their future risk of prostate cancer may be. If those men at age 40 to 45 have a low PSA, which is less than or equal to 1.0, they would be considered at very low risk for prostate cancer over the next 3 to 5 years and would be okay to have another PSA test in about 3 to 5 years. On the other hand, if the man has a baseline PSA of 1.1 to 2.4, this is more intermediate risk, and the man should consider annual testing. And if the man, this younger man, has a PSA greater than 2.5, placing him at higher risk for prostate cancer, he would want to potentially see a urologist to have a shared decision about whether he would choose to undergo a prostate biopsy at that time or be followed more closely. And again, in men with these low PSAs, annual testing is not needed. I do think the AUA policy of every other year testing for men between 55 and 69 makes sense and is a good policy. Perhaps the most controversial is how to discourage PSA testing in older men. Certainly, we do not want to practice age discrimination, and we certainly want to take an individualized approach to healthcare. But I do think it's important for physicians to have conversations and shared decision with these older patients to determine if they want to continue PSA testing or start down the PSA pathway if they're over age 70. Now, I want to just show what I think is the strong point of baseline PSA. This was a paper that I was part of with Dave Crawford from the University of Colorado and other investigators, including Curtis Petaway, where we looked at a large healthcare system, and the bottom line is we showed that if a man has a baseline PSA greater than 1.5, his long-term risk of prostate cancer is pretty high. Specifically for Caucasian men or white men, if a man has a baseline PSA greater than 1.5, he has a 15-fold increased risk of prostate cancer over the subsequent next 5 years. For African American men, it's even more striking. There's a 19-fold increased risk of prostate cancer over the next 5 years if that African American or Black man has a baseline PSA greater than 1.5. So again, I happen to be a fan of baseline PSA in younger men to determine a man's future risk of prostate cancer. And again, we're back to shared decision, trying to make decisions with individual patients as to what they want to do. Do they want to have PSA testing or not? And while this sounds wonderful on paper and while this sounds wonderful in professional societies' guidelines, the challenge in real-world medicine is doctors are very busy. Primary care in particular, they do not generally have the time in a typical doctor's visit to give the time necessary to an in-depth discussion on the pros and cons of the PSA test. And that was borne out in a recent study where this was published in the Annals of Family Medicine, where they asked patients, 3,000 older men, did a doctor ever discuss with you the advantages or disadvantages of the PSA test? And 65% of men said no. Did a physician ever talk to you about scientific uncertainty of the screen? Almost 88% said no. So the key teaching point here is that shared decision is wonderful, should be done, but with the pressures we all faced in real-world medicine, it's not being done. And this is a challenge. And finally, this was an interesting headline, Science or Politics? The U.S. Preventative Services Task Force recommendation on prostate cancer screening 1 year later. And this article implies that there was politics involved in the U.S. Preventative Services Task Force, and there may have been some reasons why not all the data was considered. One thing that's been most controversial is the U.S. Preventative Services Task Force had no prostate cancer experts on the panel. There were no urologists. There were no medical oncologists. There were no radiation oncologists. And the reason is that they felt that all specialists who would deal with prostate cancer would automatically be biased in favor of PSA testing. And so the solution to that was to include all prostate cancer experts on the panel and only include primary care physicians and epidemiologists. And that's been extremely controversial. In fact, there has been a bill placed before Congress to remedy this situation, requiring the U.S. Preventative Services Task Force to have specialty experts on the panel, although it's not clear to me at this time how that bill will fare in Congress. Finally, with regard to the issue of PSA monitoring, let me just spend the last few slides on this area. We clearly use PSA in risk assessment in men with newly diagnosed prostate cancer. The PSA level is critically important in determining how that man may be treated or how that man may be followed. And this slide just illustrates that. This just shows that when we have a man with newly diagnosed prostate cancer, we use the PSA level, the PSA velocity, which is how quickly the PSA was going up prior to diagnosis, and the PSA density, which is a measure of the PSA versus the prostate size, to better risk assess those patients as to their likelihood of having metastatic disease or their likelihood of being cured with surgery or radiation. Now, with regard to radical prostatectomy, surgery essentially should eliminate all prostate cancer tissue. And so, in theory, the PSA should be 0 after a radical prostatectomy because the prostate gland, which produces all of the PSA, is gone. Now, in practical terms, the half-life of PSA protein is 2.2 days. So after a radical prostatectomy, it takes about a month for the PSA to work out of the patient's system. But in practical terms, most of the time, surgeons would wait 6 to 12 weeks before they would do the first post-op PSA to make sure all the pre-op PSA was out of the patient's system. And there's some pretty good data on what to expect for PSA and rising PSA after radical prostatectomy. So this was a very important paper that came out now, gosh, in 1999. So it's a fairly mature study. We refer to it as the Pound article, but basically it looked at a group of men, almost 2,000 men who had had a radical prostatectomy at Johns Hopkins, and looked at PSA failures, or patients who had a rising PSA. And the key teaching point on this study was that even though the PSA level predicted early recurrence, it was a long time, on average 8 years, from when the PSA first became detectable until a man had metastatic disease, and then another 5 years before the patient would be expected to succumb or die from prostate cancer. So the natural history of a rising PSA after radical prostatectomy is quite long. And furthermore, the paper taught us to use Gleason score, the grade of the cancer, the PSA doubling time, and when the recurrence occurred, to help stratify men as to their long-term risk of having metastasis and dying of prostate cancer. So this was the first paper that taught us about risk stratification for PSA recurrence after surgery. And then before we leave this topic of recurrence after surgery, the consensus definition of recurrence after radical prostatectomy is a PSA greater than 0.2 nanograms and rising. So if you're in practice, following a man after surgery, you like to make sure that the PSA is staying less than 0.2 in follow-up. But if the PSA consistently goes above 0.2, this would be the earliest indicator of a cancer recurrence after a radical prostatectomy. After radiation therapy, defining PSA recurrence is a little more tricky because the prostate gland remains in situ, or the prostate remains intact. Cell death takes longer during radiation. So it takes a while to clear the cancer cells. And you can have PSA fluctuations, or what some people call PSA bounce, as the radiotherapy is having its impact on the prostate gland. And the first consensus definition for what constitutes a PSA failure after radiation happened in 1997. And at that time, the consensus was that in a guy who's been through radiation for early stage prostate cancer, you want to measure PSA every 3 to 4 months during the first 2 years and every 6 months thereafter to look for recurrence. PSA recurrence at that time was defined as 3 consecutive increases in PSA or a single rise so great as to trigger the initiation of hormone therapy. And what was really confusing was the date of failure is the midpoint between the post-radiation nadir PSA and the first of 3 consecutive rises. In other words, you had to wait for those 3 rises, and then you would backdate the recurrence, which sometimes worked in academic practices or in research papers, but in practical terms was very difficult to manage in the trenches taking care of patients. This slide just illustrates that with regard to radiation treatment, since the prostate is still in, one's definition of a success or one's measure of success can depend on how you define PSA recurrence. And as you see here, so let me go to this other box here. If you look at this, where if you define PSA recurrence one way, then perhaps 50% of the patients had a good long-term disease-free survival. But if you define PSA recurrence more aggressively, practically all the patients will have recurred. So it became obvious after a couple years that this 3 consecutive rises and backdating the recurrence was not really useful. So more recently, ASTRO has updated their recurrence definition. It's now called the Phoenix definition. And basically, you don't really define recurrence after radiation until the PSA has gone 2 full points above the post-treatment nadir. So let's just use a specific example. Let's say a man had prostate brachytherapy. He had seed radiation. And after the treatment, his PSA level went down as far as 0.2, which was his PSA nadir. His recurrence would happen then when his PSA went above 2.2. Again, 0.2 was his nadir. 2 full points above that would be 2.2. So even though we might be concerned before that, we wouldn't define him as recurrent until his PSA went to 2.2. Now, I'd like to end here, and so that we have plenty of time for questions. And what are the key take-home messages from this presentation? Well, population screening for prostate cancer remains very controversial. As a urologist and someone who cares for a large population of men with prostate cancer, I tend to be an advocate for PSA testing and do feel that the benefits outweigh the risk. On the other hand, you heard me present data from the 2 randomized trials basically showing lack of consensus. While the American trial called PLCO, in my opinion, was fatally flawed because more than half of the patients in the control group also had PSA testing, other experts, including members of the U.S. Preventative Services Task Force, felt that the PLCO trial was valid and used those trial results to give the PSA tested B rating. I would also contend that PSA screening is certainly not perfect, but I still believe it does remain the most useful serum screening test in all of medicine. And finally, we did look at the use of PSA testing to monitor disease, both in risk assessing men with newly diagnosed prostate cancer, as well as following patients after radiation or following patients after surgery or other treatments. So with that final comment, I do want to mention that in order to obtain continuing education credits, please now or at any time here after this program, go to www.bioconferencelive.com/CME-CE. And we'll leave that on the screen for a little bit. And at this time, we would love to entertain questions or comments. There's a question that has come in from a certain part of the country that wants further clarification on baseline PSA. And again, what we were talking about in practical terms is, let's say you have a man in your practice who is coming in for a well physical, and he has now crossed the age 40 threshold. My opinion and that of many experts would be to obtain a baseline PSA on that individual as part of his over 40 physical. And if that PSA level is low, in this case less than 1.0, and he does not have a family history of prostate cancer, one could then reassure him that his baseline PSA was very good, less than 1, and he would be advised to have another PSA test at his age 45 physical. On the other hand, if that man coming into screening or testing at age 40 had a PSA between 1.1 and 2.4, which would be considered an intermediate gray zone, we would counsel him to consider having annual PSA testing, especially if he were African American or if he had a family history of prostate cancer, which would increase his risk somewhat as well. And then finally, if his baseline PSA at 40 or in the 40s was 2.5 or greater, we would recommend that that man be referred to a urologist who specializes in PSA or prostate cancer to discuss the pros and cons of prostate biopsy with that individual man. So let's see if there's any other questions that are coming in. Let me look at the question box here and see. There appears to be another question about radical prostatectomy in PSA. Radical prostatectomy is certainly one of the most popular treatments for prostate cancer. And it's done both by the robotic technique or by a small incisional technique called a retropubic prostatectomy. And in younger, healthier men with early stage prostate cancer, the vast majority of these men can have a nerve sparing technique so that they can regain their sexual potency. And in the modern era, with experienced surgeons, there's a very low risk of permanent urinary incontinence. Now, after this surgery, the PSA should be essentially 0. However, there can be some minor amount of PSA due to minor amounts of residual benign prostate tissue that may be intertwined among the nerve bundles which were peeled off the sides of the prostate. So in practical terms, men after radical prostatectomy should have PSAs generally less than 0.2 or 0.2 of a point. If the PSA goes above 0.2, one would typically monitor it a little more closely. And generally speaking, then if the PSA goes above 0.4 to the 0.5 range, many times the patient would receive external beam radiation therapy as a salvage option to eradicate any residual microscopic prostate cancer in the area where the prostate used to reside. So that again, I hope that answered the question about PSA after surgery. Should be less than 0.2. The trigger for treatment typically, though, is a little bit higher, more in the line of 0.5. And so here's a couple of other questions. In your opinion, what would be the baseline PSA levels to patients to undergo in your opinion, what would be the baseline related with PSA levels to undergo a patient to a radical prostatectomy? I think the questioner is asking, like, how high can the PSA be? Typically, you don't want to do a radical prostatectomy in a patient who has metastatic prostate cancer. So in general, most of the time, we would generally not offer surgery commonly when patients have PSA levels above 50. However, it's difficult to answer that question because there are sometimes very young patients where we take a very aggressive stance, where we know we're not going to cure them with surgery, but we do surgery first with planned radiotherapy second, and even planned systemic therapy after that. What is the role of free PSA in cancer diagnosis? So we didn't have a lot of time to talk about free PSA, but basically free PSA is a component of the PSA protein or chemical that is free floating in the bloodstream, that's not really attached to other binding proteins. And we know from multiple studies that the more free PSA you have in your bloodstream, the better. So free is good in the sense that the higher that free PSA is, the lower the risk of prostate cancer. And so as a urologist, I use free PSA selectively to make decisions on whether I do a prostate biopsy on a man with a mildly elevated PSA, or if I do a repeat prostate biopsy on a man who's had a prior negative biopsy but who still has an elevated PSA. So free PSA is FDA approved. It's very clinically useful. Typically, the patient would get just a regular total PSA as his baseline PSA screen, but then we would use free PSA as a secondary screen to fine-tune that man's risk for prostate cancer. Here's another question. Is PSA always expected to decrease from the PSA at diagnosis after radiation therapy? The answer to that is yes, we would always expect the PSA to decrease after radiotherapy. However, there's a concept of PSA bounce. In plain English, sometimes during or right after radiation, as the prostate tissue is dying out from the effects of radiation, you can actually see PSA leach or leak out into the bloodstream, where you can get temporary blips or up elevation or, spikes in the PSA, which eventually will come down. So you can see these PSA bounces sometimes as far as 15 to 18 months after radiation therapy. And you want to be clinically careful not to be over aggressive and over-treat those men based on their PSA, because it just may be a PSA bounce. Here's another question, and these are wonderful questions. I really appreciate the audience being interactive here and asking these questions. Are your recommendations as to the advisability for PSA screening different for hypogonadal men taking testosterone? It's an excellent question. And that's always a classic board question on our urology exams. So if you have a man who has low testosterone levels, which is we also know as hypogonadism, which is a hot topic today. You can't watch the national news anymore without seeing some ad for testosterone replacement therapy. So generally speaking, men who have low testosterone would have lower PSA levels. And so the key teaching point is if a guy comes in with hypogonadism, and let's say his PSA is 3.2, you might be more inclined to biopsy that man than you would if he came in with a normal testosterone and a PSA of 3.2, mainly because PSA is an androgen, regulated protein or regulated gene in a protein. So low T levels would indicate lower baseline PSA, but his real PSA, if he had a normal T, would be higher. So you might want to consider biopsy at slightly lower PSA levels. The other thing is that we are seeing, I think it's critically important, certainly before any physician places a man on testosterone therapy, it's critical that he screen that man for prostate cancer using PSA. That's really not population-based screening. That's using PSA kind of more in a differential diagnosis mode in someone that you're treating for another disease, which is hypogonadism. So here's another question. When is surgery the best option in prostate cancer patients? Well, that's a very great question, but also we could spend another hour of BioConference just discussing that. In general, the younger and healthier the man is, with the more serious prostate cancer, the more radical prostatectomy should be the first step in the equation. As an example, a 40 or 50-year-old man with Gleason 7 or Gleason 8, those men are best served by radical prostatectomy. Those men may also need radiotherapy postoperatively. And so I never try to sell radical prostatectomy in the context of the only treatment available. I specialize in high-risk prostate cancer, younger men who really need an aggressive approach. And many times I'll work with my radiation oncology partners to plan surgery first, and then we plan radiotherapy second. In general, radical prostatectomy and radiotherapy are both excellent options for men with localized prostate cancer. We don't, unfortunately, have any randomized trials to tell us who might be a better candidate for surgery versus a better candidate for radiation therapy. But I think in general, both urologists and radiation oncologists would agree that the very young men who have the most serious cancer are probably better served with surgery first, and then, but putting that surgery in the context that they may also need radiation therapy to follow. And then I think there's one more, we have maybe time for one more question. And the question is prostate biopsy therapeutic or preliminary step to surgery? Well, certainly the only way to quote unquote legally diagnose prostate cancer is with a tissue diagnosis. You certainly can't diagnose prostate cancer based on PSA alone. I mean, you can have a good sneaking suspicion that a man has prostate cancer if he has a very elevated PSA. And you can also have a good indication from his rectal exam, but you can only diagnose cancer with a tissue biopsy. And so before radical prostatectomy, a patient would necessarily have to have a prostate biopsy to diagnose prostate cancer. And at our institution, we also require patients to have their biopsy slides receive a second opinion by our pathologist before I'm allowed to operate on them. And that's critically important now in the modern era, especially if we see small amount of low-grade cancer. We want to confirm that that man truly has prostate cancer before we will recommend proceeding on to a radical prostatectomy. Well, we are down to the final seconds. And again, I'd sincerely like to thank everyone for joining. It's been a great pleasure. Have a good afternoon. Good day.